Introduction to Quality Assurance. A quality management system is pretty complex. So when we look at each one of these individual components, the first one, SOP. SOP stands for Standard Operating Procedures. SOPs are critically important to ensure that every tech that's working in a particular area of the lab is performing that test in an identical way. So it's a protocol basically that everyone that performs that test must follow. That protocol also includes information about how to ensure the quality of the patient result. Competent personnel. So once you get certified and you start working in the laboratory, we got to make sure that you maintain your current knowledge of the field and continuously demonstrate that you are capable of producing valid results. So we do proficiency testing. We will get random samples sent from an outside institution. They come into the lab and we treat them like normal patient samples and we report results on them. And we ensure that every tech that's reporting results is reporting results accurately based on that proficiency testing. There's also continuing education requirements as part of maintaining your credential. So every healthcare association, every clinical facility has some type of continuous education requirement. Instrumentation. So every instrument that's used in the lab has to be QC'd and maintained. The maintenance will prevent errors down the road, and each instrument has usually a maintenance log and a QC log, and some instruments have to be calibrated regularly. So all of that documentation is around instrumentation. Reagents. Reagents must be stored at the appropriate temperature and must not be expired. They have to be used within the time frame allotted, and any reagents have to be properly labeled. So reagents can be a source of error in the laboratory. Sample management. So we'll talk a little bit more about this as we go through these slides, but when you have a patient sample, it has to be treated correctly in order to produce the correct result. So whether it has to be blocked from sunlight for certain tests, or drawn in a certain way, put in a certain tube, added certain types of preservative to the sample, transported at a particular temperature or within a particular time frame. So all of those sample considerations need to be taken into effect. Resulting. So even though an instrument produces a result, it doesn't mean that a tech can go ahead and report the result. We have to ensure that result reporting is accurate, and we have to do that by verifying quality control in our quality assurance system. Record keeping. So record keeping is vitally important because hospitals usually run 24/7, so there's never like a downtime. They always have new specimens coming in because people are always getting sick. So because there's a first shift, a second shift, a third shift in most hospitals, we need to have a centralized way to communicate what's been done to each patient sample, each reagent, each instrument, and so forth. And that's through record keeping. So we keep records so that when a new tech comes in for the shift or takes over a position within a particular area, they can go back to those records and determine if the patient's results are valid going forward. Error detection. Error detection can happen when we sense that there's been an erroneous report. So sometimes a tech may submit a final result and then it gets verified later and found to be incorrect. So detecting those errors and then calling for an error correction or an updated report, those are all part of making sure that even when errors happen, we follow up on them. Performance, so we want to ensure that the entire laboratory is performing at its highest efficiency. So this is where we can sometimes get into talks of Lean Six Sigma. Lean meaning cutting down the waste, and Six Sigma meaning finding faster paths to get the desired outcome with very little error. So performance of the entire laboratory can be evaluated by external entities, and they can provide some suggestions for improving how the lab in general operates. CQI, continuous quality improvement processes. So continuous means it's ongoing, and quality improvement, which means ongoing, trying to find ways to make the system work better. So that can be incorporated into a quality management system, and oftentimes is. If there's a path to make a process go more smoothly, we should be taking an advantage of that, because that reduces the amount of time it takes to get patients the results they need, or physicians for the patients, so that they can be treated appropriately. Customer service. So we serve the patients, but we also serve the physicians and nurses that are treating the patients. So maintaining a positive customer service basis is vitally important to maintaining the overall atmosphere of the hospital environment. And facilities and safety. So we always have to make sure that our facilities are safe, and that our facilities are up to date and clean and neat and organized. Safety kind of follows along with facilities. So we want to ensure that everybody's practicing safe laboratory practices, that there's documentation of safety training going on, and that safety precautions are being used to reduce the risk of exposure of our laboratory personnel with something that a patient may have in their specimen. So a quality management system overall is the coordinated activities to direct and control an organization with regard to quality. Quality assessment versus quality control. So quality assurance or quality assessment seeks to minimize errors of all kinds. It's a broad program encompassing many things and includes a quality control program. Quality control is one small part of quality assurance. So quality assurance looks at big picture. How do we streamline the efforts of the laboratory? How do we get instruments properly functioning all the time around the clock? How do we get accurate results reported, and how do we reduce errors everywhere in this organization of the laboratory? While quality control is a very specific part of quality assurance. And quality control looks at QC samples or known samples that are used to detect an error in the system. So when you run a patient sample on an instrument, we usually also run a positive control that's known to be positive and a negative control that's known to be negative. If our controls are accurate and fall within an appropriate range, then we can safely assume that our patient sample is accurate. If the QC results are not good, then the patient results are also suspect. So quality assurance, the process in which instruments and methodologies are monitored to ensure an accurate result. Monitoring of any activity that is associated with the laboratory result to determine potential error. There's pre-analytical activities. These occur before the sample reaches the laboratory. So is the nurse or phlebotomist drawing the specimen correctly? Is the specimen going in the right transport container or tube with the correct preservative? Are the specimens labeled correctly? Are we having mismatched patient samples going on? So all of those things occur before the sample actually reaches the laboratory. Transport time, transport temperature. So all of those are considered pre-analytical activities. In this program, in the MLT program, you will hear a lot about pre-analytical, analytical, and post-analytical. So we harp on this regularly through every class that you're going to take in our program. So these terms are absolutely essential for you to understand in this course. Analytical occur in the laboratory and directly deal with the analysis of the sample. Are we adding the correct reagents? Did we QC alongside our patient samples? Are we performing the procedure according to our standard operating procedures or the published protocol? So those types of errors occur within the laboratory. Post-analytical activities are activities after the analysis is performed. So after the instrument reports the result and we get that information as a tech, are we then actually going and looking at the QC results? Are we looking at our QC charts to make sure that the QC is falling within range and our patient samples are falling within an expected range. So, and then calling critical results. Are we recognizing that a particular result is critical and calling that up to the floor? Are we validating results before reporting them as final? Monitoring is part of the quality control plan. So pre-analytical, we're talking about sample management and interferences. Analytical, quality control, method validation, proficiency testing. So that proficiency testing, we're talking about that outside organization sending in random samples that we treat as patient samples. And then we have to report out the result that we get. And then that outside organization ensures that, yep, they are competent. They're able to report out accurate results. Method validation has to do with choosing the correct method and the appropriate method for a particular result, and that's something that we'll talk about in the next unit. Post-analytical, interpreting data, reporting it accurately, and documenting. And interpretation has to do with quality control. So if our quality control is in the correct range, then we interpret it as being okay. Reporting, we go back and look at the method we used. Is the method validated? And if it is, then we can report out the accurate result. So quality control programs, the goal of a well-defined quality control program is to detect immediate errors in the analytical run while minimizing the number of false rejections. One rule, the simplest type, the 95% range, which means 5% give you a false reject. False rejects are false alarms. The testing system is acceptable by the QC and the value is out. Multi-rules are set up to avoid false rejects, and those are called Westgard rules, which we'll talk about in this series of videos. 2 levels are also recommended for each analyte. Sometimes 3 are used. Values are chosen based on useful limits of the analyte, medical decision levels, or analytical measurement range. Quality control types, internal, are performed daily in the lab. So those are your QC samples that you run alongside your patient samples. They're reported every single day. External are proficiency testing. So those are those external organizations that send in specimens to make sure that our lab can process the specimens correctly, and that's performed occasionally. Both types of quality control are required by federal regulations. Many times, a large quantity of quality control material is purchased. A single lot number may be purchased for long-term use, but must adhere strictly to the storage requirements and must always be reconstituted according to the guidelines. One of the big things with reconstituting, so we're talking about reconstituting usually means that something is given to us in a concentrated or freeze-dried, lyophilized type state, and we have to resuspend it in some solution. Then we usually freeze that or put it in the refrigerator or put it at whatever temperature we need it at, and then we can use that regularly until we reconstitute a new subset of that QC reagent that arrived. Now, one thing that we need to be cognizant of is freeze-thaw cycles, especially when we're talking about certain types of reagents. If we repeatedly freeze them, thaw them out, freeze them, thaw them out, after so many times, crystals can form, and that crystallization can interfere with the quality of the quality control reagent. So something to consider is follow those protocols and read if repeat freeze-thaw cycles should be prohibited, then you want to make sure to follow that. Lot-to-lot comparison studies. They must be analyzed for at least 20 consecutive runs over 20 to 30 days to establish mean and standard deviation. Statistical analysis of control samples is based on the assumed Gaussian distribution of the data. Individual quality control plans. Each laboratory is responsible for establishing its own criteria for acceptance or rejection of quality control results. Requirement of CLIA 88 that minimum of 2 levels of controls be used daily for most methods, unless the lab writes an IQCP. States you must follow the minimum recommendations of the manufacturer. If they choose to deviate from the manufacturer, then an IQCP must be written. The parts of the IQCP would be a risk assessment, that's evaluating the risk of creating one and the risk of using one, a QC plan, and a QA plan. QC terminology. So accuracy and precision were defined previously in this course, but accuracy is how close to the value, or how close the value is to the true value. So is the value correct? Or how close to being correct is it? Precision has to do with the repeatability. So if I were to run a sample 15 times, I would get about the same answer all 15 times. Bias is the difference between the average values and the true value. Shift, a sudden and sustained change in quality control results above or below the mean. A trend would be a gradual but steady change in quality control results, moving up or down away from the mean. Errors that cause a method to be out of control. Random error and systematic error. Random error is error based on chance. Example, a 100 ml pipette only delivers 90 ml. Routine maintenance and calibration are key to avoid random error. And this is related to precision, because once something's not calibrated correctly, every result is going to read off. Systematic error affects all samples. For example, improper storage of reagents. Two techs performing a method differently. Again, maintenance and calibration, also proper training to ensure that that doesn't continue. Quality control material. This is the material that's analyzed along with the patient specimens, and it should be treated the same as patient specimens. It should be of the same matrix as the patient sample. The matrix, the chemical and physical characteristics of the material that contains the analytes to be measured. What is an acceptable limit for my quality control material result? If the QC result is outside of the acceptable limit established by the laboratory, the patient result should not be reported until the problem is solved. No patient results should be reported out until the method is in control. A system is said to be in control when the values fall in the expected range and out of control when corrective action must be taken. Troubleshooting problem may be with the sample or the system. Is the problem with only one control, only one test on a system, only at a certain time? If the problem resides within the QC material, no repeat of patient results. However, if the problem resides within the assay system, all patient samples must be repeated going back to the last valid quality control run. So this is an experience that I had. So we were doing molecular detection of some type of gene, and our QC material kept coming up with an error. But we ran like 20 some patient samples on this machine, and all of our patient samples were correct or were valid. Even though the QC failed, we had a strong indication that it was due to the QC material, not due to the actual instrumentation. So all of those patient results were put on hold. We did not report them out until we changed up our QC material. Once we changed out the QC material, the QC read correctly, and because the QC worked, all of those patient samples were able to be reported out. So we did not have to go back and repeat them because we found that it was an issue with the QC material and not an issue with the whole instrument or the assay itself. Now, if there was an issue with the assay, so let's say no matter what we did with the QC reagents, we couldn't get it to work, then we would have to troubleshoot the assay or troubleshoot the instrument before we could then rerun and get accurate results for QC and all the patient results.